Good morning, everyone. Thank you for joining us this early. We really, really appreciate it. This is the Healthy Places Research Group, hosted by the Center for Quality Growth and Regional Development, CQGRD for short. And my name is Dr. Arti Rao. Dr. Catherine Ross is the director for CQGRD, and I am a part of her team. And I am delighted today to welcome, on behalf of CQGRD, our panel of experts who work at really very different levels of the built environment, but nonetheless very important. And they're going to talk to us not only about, a little bit about their backgrounds and how they approach the research and practice in this area of research and practice in the sense that how they think about the built environment and research. But they're also going to talk to us about their work during the COVID pandemic, particularly thinking through how we can approach health from the socio-ecological model and really help communities in a much more holistic way, really looking at the social determinants of health and all that we know as planners are important. So with that, I'd like to welcome Dr. Sagar Shah, who is the manager of the Planning and Community Health program at the American Planning Association, Dr. Whitney Austin Gray, who is the Senior Vice President for Research at the International Wellbeing Building Institute, and Carol Babcock, who is the Director of Palliative Care and Healthy Communities at Navicent Health. And with that, I would like to hand it over to the panel, and we can do introductions first, and then they're going to have a little bit of a background about their research and how they got into this area, and then they will talk about their COVID-related projects. So take it away.
Great. So do I start then?
Yes. Go ahead, Whitney. Yes.
Great. So we're just doing introductions and then we'll start the slides?
Yeah.
Okay, perfect. I love this early bird crowd. Catherine, I can see you out there waving. This is so much fun. Chisholm, I hope I'm saying that correctly. I miss presenting to real life three-dimensional people, so it's great to see your faces and your smiles out in the ether, and look forward to meeting you someday in real three-dimensional land. So I'm Whitney Austin Gray. I lead research at International Well Building Institute. My PhD and background's in public health, but I kind of describe myself a design groupie, the person that follows the band around because she just loves designers. I love hanging out with them. I love learning from them. I love their creativity. And it's really an honor that at the International Building Institute, I spend my time translating research to practice and learning from those designers that are every day saying to us, what are the real issues we're hearing from industry around applying what we know about air quality and water quality? What do we do about sound, materials, access to healthy food and movement? And so every day we work to improve that through the Well Building Standard, and I'll be talking a little bit about that today. I will say that a passion of mine is the students out there pursuing this work. I remember when I was a student at Johns Hopkins and there was not a design school. A great place for public health, but I was trying to find my community. And I'm really glad to find them. And so I still teach at Georgetown and really hope to engage and support the community out there of academics and students. So it's an honor to join you today. Thank you.
So Sagar, do you want to go next and just introduce yourself and tell us a little bit about your background?
Sure, yeah. Hi, my name is Sagar Shah and I work at American Planning Association. As you can say from my accent, I am from India, and I did my internship from India. Can you hear me okay?
Yeah, the feedback's gone.
Mm-hmm. Okay, from India. I did my architecture there, and I was working there for a few years. After that, I was really interested into planning urban design, and that I wanted to know more about policy planning because in India, we used to focus a lot on design and not policy that much. So I came to US to do my master's in planning, did that, and then I was working with a metropolitan planning organization and thought, I was surrounded by researchers in transportation, and I got really influenced by what they were working and the cool things they were doing, especially at regional level. So I thought that, well, I was really got really interested into research in like a year and a half or two, and then applied for PhD programs. I went to University of Cincinnati to do my PhD because they were focusing on regional development planning. And while working there, my interest was initially it was sustainability and sustainable transportation, sort of. And then in the second year of PhD, I just stumbled into health. Actually, we got a project from my professor, my dissertation chair, got a project from Communities Putting Prevention to Work project from CDC, and we became part of it. And I was like, well, yeah, they're going to pay me for 3 years, so why not? Why not work on it? So I started working on it, and I got really, really interested into. And of course, we know that health, sustainability, everything is connected. So I got really interested into it, and since then, I have been working at the intersection of planning and health. After graduating from the program, I was very interested in thinking about. I think, well, this too much details, but in the last 2 years of my PhD, I was forced by my professor to think about practice, which I had never thought about before. It was like only about like academic research, right? Methodology, data, etc., etc. And I was forced to think about practice, and I thought that a lot of the planning academia, and I think even in public health, better in public health, but at least in planning, people don't think about practice that much when they're doing academics. So I thought it was really important to connect planning practice and research. And that's why when this opportunity came up where APA wanted somebody to, in the planning and community health program, I'm like, awesome, this is amazing. This is like completely fits my goal, personal goal, but also my subject area interest. So that's how I joined APA, and have been working since last 4 years at the intersection of health and planning, but more so also about research and practice, which is very important. So mainly working on applied research projects where we look into academic research, gray literature, and then translate it into things for our tools for planners. So that's my thing. I would also like to mention to students. I know students are going to Aarti are going to show this to students as well. I would, as Whitney suggested, there are very few programs in the United States where they have joint program, like University of Washington has joined between built environment and health. But there are very few programs. But I have seen more and more people, at least in last 5-6 years, doing both masters in public health and masters in planning together, and then working cross-sectorally. I just got like 2 emails last week from two people who are public health people, and then now working in planning departments, which was strange because I was mostly seeing planners working in public health department. But this was really great. I got an email saying that, hey, we would like to know more about planning and would like to talk with you in terms of what do planners exactly do and stuff, which was really nice. So I would encourage all of you to think about, especially students, to think about cross-sector and how all of us can work together, because we are all working towards the same goal. Yeah,
Thank
that's
you
it.
for that, Sagar. Thank you so much. Carol, you're on next.
Okay, this is Carol Babcock, and I'm the director for palliative care and healthy communities at Navicent Health in Macon. We're a pretty large hospital in Georgia. And I don't know how to switch it to where you can see me mostly, so you're just going to have to keep looking at Saga while I talk. You might want to just lip while I. Okay, so.
We can see you. I'm seeing you, Carol.
Okay,
yeah,
good.
We're seeing
Great.
you.
Okay.
Yeah.
It's very interesting to me. My background, my undergraduate degree was in psychology, and for some reason, when we got into statistics class, everybody was grumbling and hating it, and I loved it. I mean, there was something about it that just really attracted me, and from that point on, I went more into social services. I got a master's degree in family therapy. But all along, I have always used data to be able to prove programs that I do. I do a lot of planning and design for the programs that I have built. I was the one that built our palliative care program, and that's been going for about 18 years now here at Navicent Health, and is very robust. We did research in that area around race and decisions on end of life, and also just the model of combining family therapy type services in with palliative care. And then more recently, I went and became certified as a Six Sigma Black Belt, and have really used that toward design as well, using the lean methods and really getting in and determining how to build healthy communities. When I first was given this task, we called it population health, and one of the senior vice presidents came to me and said, I would like for you to rethink this, and I want you to call it healthy communities. And I went home that night a little bit overwhelmed, thinking, how do we make our community healthy? I mean, that's a major task. And where do I start? There's so much work to do, but the more I thought about it, the more excited I got. And so today I'll be talking to you about how we took that and built it from ground up, and without a whole lot of resources financially to be able to do so. And so this is really my passion, is to start new programs. I do travel to other areas and help them start up their palliative programs, and also now doing population health. So I'm so thrilled to get in touch with like-minded people. So thank you for letting me be here today.
Thank you so much. That was. Oh, sorry. It looks like. I'm not sure where the feedback is coming from, but I think that was exactly the kind of information that I teach a class in built environment and health, so really learning about this is so valuable for the students who are going to watch this panel asynchronously in a little bit. So this is very valuable and very encouraging for them to hear all of this great information, and how people can take different paths to come into this area of research and practice. So thank you so much for that. With that, I'd like to move on to, looking at, particularly in this pandemic and these very, very extenuating circumstances, what are all the things we can do as built environment and public health professionals to come together and help communities cope and recover with these very strange circumstances. So I'd love to hear all of the great work that y'all are doing and are involved with, particularly around the COVID pandemic. So we'll go in order. Whitney will start with her projects, and then we'll have Sagar, and then we'll have Carol. Please feel free to enter any questions that you have into the chat box, and we will be closely monitoring the chat box, and we will are you all comfortable taking questions spontaneously, or do you want to wait till the end of the panel? Okay, so if you have any questions, as the slides are progressing, please post them in the chat box, and then we will pose them to the panel. Thank you.
Great. Well, hi, everyone. I just want to make sure everyone can see my screen. Yes, nods. Okay. Thanks, Sagar. Yes. Appreciate it. Well, my work on a daily basis is as a built environment and health professional is translation of research to practice. And so I really wanted to represent what we are learning from the field and what we're trying to do to create tools that can really harness market forces and to help inspire market transformation around healthy buildings and healthy communities worldwide. So as a quick primer, and I'm looking at all of my photos on the screen, but are people familiar with the Well Building Standard in part? Okay, so I'll just give a quick primer for everyone. We do focus in the built environment, and many people are surprised to find they spend 90% of their time there. I think everyone knows that on this call, but to put into perspective, if you're 40, that's 36 years of your life. And so the people that work in the indoor environment have a critical role to play in our health. And we know that because of the determinants of health and the large role physical and social environment plays. In fact, I would further argue epigenetics and the role of the environment, and also influencing even gene expression that we're learning. learning. So I think everyone understands that background. But what's challenging is that there's a lot of buildings out there and communities that say they're healthy, but how do you know it? And when I ask people, do you want to live in a healthy building? I mean, I haven't found anyone that said no. But how do you measure what is healthy? And is it enough to say that you're a healthy building and you have good air quality, but you don't have access to good food? And is it a healthy building if you have great natural light, but at the same time, you don't really have access to good mental health? So these are the balances that we work with every day, and we hear from our clients, if I only have this much budget, what do I focus on? What's more important for my health than others? And that roadmap becomes very important to help people understand how do they balance all these components of public health. And I think because I'm speaking to the building health community, I would say too that a lot of us are trained in one discipline over the other. And as a result, oftentimes we have representation from those that are experts in air quality, but they may not have connected with those that are mental health or mental well-being experts. And so we also believe at the International Building Institute that as translators, our goal is to bring these communities together. And we actually host a series of advisories in which I would encourage and ask and invite everyone on this call to think about being part of. And those advisories help us to balance the daily questions of what program for mental health and well-being is balanced with what do we spend on ventilation, filtration, and source control in buildings. So we also touch the operations of the building and the behavior. And so I will sort of go over a little bit about the well building standard and how we do that in all the different categories. We are global in scope. I look at this map longingly and remember the days when we were in Boston and Belfast and Dubai, and it's been quite an honor to work with people around the world. I mean, people are 99.8% genetically similar, but places are very different, and so is the culture behind that. And so we've learned a lot from our partners internationally as we've launched the well building standard in now actually 64 countries as of this morning.
Whitney, we're actually seeing your I think your notes page
okay.
rather than.
That's okay. You guys can see my notes too if you'd like. I think it has to do with how Blue Jeans is sharing the multiple screens. So let me try to switch it real quick, but I think at this point I can just get through the presentation and people can ask questions as long as no one minds the screen too much. Let's try this. Is that better?
Whitney, you can go on the top left side and say swap displays. Do you see that?
Yep.
Yeah, that one. Yep.
There we go.
Perfect. All right, great. So these are the 10 concept areas of the well building standard. Again, emphasizing that we balance issues around air, water, sound, materials with mind, community, movement, and access to healthy foods. So I'm not going to speak about all of them today, but I wanted to respond particularly to what we're doing around COVID-19. And so this is the feature we focus on around air. So in the well building standard, we just released well version 2, and we asked that projects look not just at performance metrics around thermal comfort, around air quality issues, humidity, but we also are tracking particulate and particulate matter. We look very closely at filtration maintenance and require that, particularly important, of course, as we're responding to COVID. We look at construction pollution management, of course, smoking bans, and we do address microbe and mold control in the standard. And I'll get into more detail specifically about how we do that in the well building standard. I do like to remind our audiences that indoor air quality is not regulated the same way as outdoor air quality. And in the most recent Global Burden of Disease study, we know that household air pollution was rated as the 10th most important cause of ill health for the world's population. And so really trying to understand how we can improve air quality and also empower users around understanding air quality. I give a different lecture around making the invisible visible, and around how our communities are really trying to understand what is clean air. And if you can't see it, then how does knowledge play a role in conveying that message? And that's particularly important now. I did mention mental health here, so I'll just pause on this slide for community. We really are trying to empower our designers and architects, sustainability experts that are in the field, that yes, we launched as a building standard, but we really think that we support healthy organizations that also need to look at policies around mental well-being and community. And so these are quite a few strategies within the Well Building Standard to do that, including, which I can appreciate, new mother support, since I have almost a 6-month-old at home, as well as emergency preparedness plans. And this has always been part of the Well Building Standard before COVID as well. So, and a lot of the organizations that look to us for these strategies, they may already have health and wellness programs, but we do think that the overall, when we're able to change the built environment and create safe and healthy places, that we can influence 100% of the population. Whereas on average for organizations over 1,000 people, you see participation levels at around 15% for workplace wellness programs. And there's a lot of barriers to that. But we do believe that when we create those healthy staircases and we can create cleaner air, that we actually can create clean, safe, and healthy environments for people that 100% can participate in. So here comes the translation and the tools. I won't speak about all of them today, but I do want to emphasize the Well Building Standard is open to all projects. So there's many experts on the line today, particularly, for example, in healthcare, Carol, and for others representing industry, for example, or residential. The Well Building Standard is being translated to all those typologies. So we need your help as we stand those up. In response to COVID-19, we launched the the health safety rating for Well, and this pulled in over 600 experts from around the world that were in a task force that helped to advise us on what do we need to be thinking of as we return to workplaces. These are 21 features that pull from the Well Building Standard version 2, and we asked projects to pursue 15 of those. And of those 15, we asked them to verify. So we are tracking whether or not they've actually followed through. This is not a checklist activity. It's really pushing them to verify. And so with that, it's been really a powerful response from the industry in saying we do need these guidelines to be able to move forward. And that's not just in air quality. We're also looking at cleaning, disinfection, maintenance protocols. Emergency plans is a big one. What happens when someone gets sick? If you have to shut down, what is the plan? How flexible is your organization to do so? And education and engagement, I just emphasize this because there's a mental health component of this pandemic, and understanding how to make people feel they're also mentally supported. And people are dealing with a lot of challenges and stresses, and so this is also part of the Well Health Safety Rating that we examine education and engagement across the organization. So I will just highlight here some of the air and water features that we put forward in the health and safety rating, which includes this very interesting conversation around ventilation, filtration, disinfection, cleaning practices, and I'm sure many of us have been in extensive calls, and Carol, we're learning so much from healthcare, and my previous work was in healthcare design. I think we're going to see a lot more translation of healthcare practices into commercial settings. And of course, mold, moisture control, air and water quality. Some of these buildings have been resting and they're now restarting. And so we want to also pay attention to the fact that buildings are not meant to rest for a long period of time. So we need to make sure that we're addressing all the systems of a building as people return to work. If you're interested in learn more, this is a sort of step-by-step guide to enroll, customize your approach, review, achieve, and then renew. But I'm really excited that we have representation from around the world, from Bangalore and RMZ to Monarco Towers, Manila. This is an incredible leadership story of an individual that really said, we're going to make a difference here in Manila to pursue the Well Building Standard as well as the health and safety rating. And then to many of our backyards here, the Yankee Stadium has signed on to the health and safety rating. And we have dozens and dozens more that have as well. So this is a resource for everyone, for the students out there, of course, and for faculty. We're really proud that we can bring these resources free. And as a lead of research, I would like to say that we encourage, and hope to catalyze research in this field. So if you'd like to learn more, please let me know. I just want to end because I am a data wonk on that. At the end of the day, I think that data can provide a language as we try to translate research into practice. And so I just wanted to highlight that we have the Well Portfolio program that allows many of our clients to test and track their wellness interventions across multiple sites. So now we have between and within comparisons. And so that's really exciting for us. And these are projects that don't even have to be pursuing well. They just want to test and track their performance across multiple buildings. We're actually even seeing this roll out at places like Adventist Health, where they have a large campus, and you're seeing, one building after the other try to come online to test and track their wellness performance. And for anyone that works within the field of ESG and environmental social governance, we're working closely with large portfolios such as Barclays to really help them focus on transparency around their investment in human capital through pursuing the WELL Building Standard. And so if you're interested to learn more about what we're doing in the investment side, please do go online to wellcertified.com, Investing for Health, and you can learn more about what we're doing to really, we believe, sort of push for transparency and materiality for companies to report what they're doing to create healthy and safe environments for their people. So with that, I know that was a fast journey, but really the take-home message here is the importance of translation of research to practice, the importance of all the work that this community does to bring that research forward, and then really just the open doors and welcome to the family. And in many ways, we've been part of this for a while together. I think that our task is even bigger in front of us, and that COVID will fundamentally shift our industry moving forward, and that we're in a powerful position to make the change that's needed and to help guide people to be able to translate the research to practice. So with that, here's my information if you'd like to learn more. Thank you.
Thank you so much, Whitney. That was great. It was so fascinating to see all of the different facets that y'all are involved in right now. And thank you for that overview. I don't see any questions in the chat box yet. So I guess we'll move on to Sagar next to talk about the APA's work in this area. So take it away, Sagar.
Let me unmute. I think when I shared my screen, I was not able to see the mute button, so I'll share again. Can you see the slide?
Yes.
Oh, awesome. Thank you. Yeah, that was great, Whitney. And I'm just realizing how bad my graphics are after looking at your presentation. Anyway, I'm glad to be part of this group and talking with you all today. Am I seeing Andy? Andy, you are like what, 4:30 a.m. there? Hi, Andy. I'm like, wow. You joined at like 4:30. You are dedicated. Hi, everyone. So what I'll do is I'll talk a little bit about the work that I do at APA and then talk specifically about how APA has responded to COVID-19 in terms of an organization and the things that we do for the members. So as I mentioned before, I manage the planning and community health program. And in this role, my main work is to help our members integrate health and equity into their planning practice. And most of our members are working at local level, local government. And basically what we do is we create educational materials, provide technical support, provide tools to them to address specific aspects of work. And this is like overall, but I specifically focus on health. These are examples of some of the projects that we have worked on Traditionally, we have worked on active living, food systems planning, health in all policies approach, health impact assessments, and have been recently working on environmental health, the connection between climate change and health, and then rural health, because we feel that planning has an urban bias, and we have a lot of things for urban areas, and sometimes we leave our rural folks behind, especially working in rural area and small communities. So that's what we are working on. Mechanisms we use to work on the projects, and this is only for like funded projects. We do three types of thing. One is applied research, and I talked about that a little bit before, where we look into the existing literature and research, and then create sort of like tools, guidebooks, etc., for planners that they can that are very handy and that they can directly use in their planning practice. The second type of work we do is place-based work, where we work with communities to help them achieve goal XYZ, whatever the goal is for their communities. So, for example, in one project, we help them either improve access to physical activity locations like parks and sidewalks and public spaces, etc. And then the other and also access to nutrition, which is healthy food. The third type of work we do is sort of create education and training. And one example is we recently completed a 4-part educational module or educational course on how planners can site early care and education facilities like daycare centers in unsafe sites. Safe meaning preventing children from polluted air, water, and soil. So these are sort of like 3 types of mechanisms we use to work on projects. Okay, this slide always takes time to load because of this 5 images, but I just want to like briefly talk about a project that we worked in 2017. And Aarti, you were the external advisory, you were part of external advisory committee, so thank you for that. There we basically identified the main domains through which planners can influence health, and the 5 things that you see on the slide are the 5 domains that we identified. We further divided these domains into subdomains, and so, for example, active living was further divided into active transportation, recreation, and traffic safety. I would like to draw your attention to the domain 4, which is emergency preparedness. And as you can see, one of the subdomains is infectious diseases. And this is interesting because the work was done in 2017, and I still remember the 2 meetings we had where we were brainstorming about like whether to include infectious disease as one of like subdomain. Is it important enough to include infectious disease as one of the subdomain? And I'm glad we did it, because now it's pretty evident that planners play an important role, or built environment professionals play an important role when it comes to tackling infectious diseases. So, and I've been part of like 2 or 3 initiatives since then where we have identified like research roadmaps, etc., etc. And we have not mentioned infectious disease, like, so I'm very proud of like we including that in this work. And I also got a like inquiry from members, and can we like expand this subdomain in the report, because we were sort of thinking about like water diseases, and not about like airborne diseases or respiratory diseases. So yeah. Now talking specifically about COVID, so that was sort of like giving an idea about like what we work on. Now thinking about COVID, we understand that the future is more, and when I say we, I mean APA understands the future is more unknowable now than before. And the only constant is change. And we all know that our lives and the way we interact with people, the way we interact with the community and the built environment has changed since March. COVID-19 has turned everything upside down. The one question that we get asked from members, but also a lot of other people when we talk about COVID work is it temporary or permanent, right? So there are a lot of changes in our life, digitization of life, working from home, etc. Are they going to be temporary, or well, in next year, by the end of next year, once we have vaccine, which is available to everyone, the life will go to the normal like before, and nobody knows that. Nobody knows what is going to happen. Of course, there are going to be some changes in our life, but we don't know what and how much those changes would affect our life and communities. So that is one thing that we are closely monitoring and thinking about a lot. And the one thing that we have started using is called, we have started a practice called APA Foresight practice. And we did not start this in March. We started this like last year when we got our new CEO, who was very interested in thinking about future based on present. So we have been working on this for some time, and this happens in March. So we were really glad that we were really quick in responding to what was happening, because we were already thinking about the future, right? So, and I'm not going to go into details of what the foresight practice is, just want to highlight this particular slide or this particular graphic, where in foresight practice, we are thinking of like 3 time zones. One is act, which is reacting or responding to what is happening right now, based on what is happening right now, which is acting. Preparing is basically seeing the trends right now and preparing, already creating resources, thinking about preemptively, thinking about what is going to happen and providing resources to our members about the trends that are happening right now. So climate change is one. Leave aside COVID, but climate change is one, right? Aging population is another one. Like those type of trends which are happening, we know it's going to change our communities. And watch and learn is a third phase where it is based on the trend, but we are not that sure about what is going to happen in like 5-10 years, right? So that the difference is basically that in act and prepare, we are doing things right now. For watch and learn, we are closely monitoring the trends to see how the trends are moving so that when we come near, the watch and learn would become like prepare because we have closely monitored those type of trends. One example is technology. We do not exactly know right now how is technology going to change planning, how is going to change public health, how is going to impact health, etc. So that's something that we are closely monitoring and watching. And when I say foresight practice, I'm talking about like the whole APA as an organization adopting it in not only planning and community health or research department. So this is very interesting, and all of us, all departments at APA are thinking about like how we can integrate in our practice. And for that, we are using three lenses. We are thinking about how the trends or what we are seeing right now are impacting our cities and communities, how it is impacting the planning profession itself, and how it's impacting APA as an organization. So it's like internal and then external, and then of course also about our members working in their own communities.
Sagar, we have a question in the chat box about the foresight, the roadmap, and the question is if there are feedback loops built into the foresight plan. Mm-hmm.
Yes, of course. And so we are working on a project right now where, well, which is funded by Lincoln, where we are thinking about where we have accumulated about 96 trends that are happening. And once we identified those trends, we went back and looked at, are they verified? Are they verified through data? So we went and looked at, like, again, example of climate change. How is climate affecting? How flooding is affecting? How the urban heat islands are affecting? So looked at the data. So the feedback is, I think, right now in two forms. One is member feedback. Of course, we hear a lot from our members, but then also looking into research and literature, because we are sort of thinking about things that planners are not thinking right now. We are thinking about stuff that planning practitioners are not thinking about. So basically looking into reports and research and thinking into organizations that are doing futuristic thinking, like Future Institute, like Future Today Institute that is mentioned on the slide right now. So we are looking into those and then getting feedback from them. I don't think we are yet there where we have like a systemized way of like well, every 6 months we do this particular process, but maybe we have to do that. We are new to this and we are learning it. It's almost like 1.5 years since we have done this, but yeah, it's a good question actually. Hope that answers the question.
Catherine? Mm-hmm.
Yeah. So moving away from, like, not away, but building on the foresight practice, I'll talk a little bit about the COVID response, right? And one of the guiding principle for our response was foresight practice. Now, so as soon as this happened in March, I think in few days, we all learned that our lives have changed, right? So the first thing we did was we created like an interdepartmental group. So the research department, policy department, marketing department, and communications department of APA came together to create this small group. I am part of that group, very, very happy that I'm part of that group, to think about how APA can respond or help our members respond to this crisis. And this is not new. I mean, creating interdepartmental groups have happened in APA before. The new thing was we were responsible for the content that APA is giving out to our members. So it was, we were like a door through which we are talking with all other departments, but also talking with our members, and then putting out things that we thought are most important to our members. And I'll talk about that a little bit ahead. So the goal that we were given was to identify, develop, curate, and quickly distribute resources to members related to COVID-19, right? And the charge was to incorporate member feedback. And this feedback is, we get it from like conferences, we get it from surveys, we got it from talking with people, we have anecdotal experiences and interactions with members. So getting the feedback from the members, identifying their pain points, and then working on those pain points at that moment. It's not about COVID-19 has expedited everything that we do. So it's about like previously planners, we are planners. So we take long time to do things, right? To make plans, etc. Here it was different. We are doing like everything very quickly. And leveraging talents. We know there are some communities, our champions throughout the nation, that are doing really good job in terms of specific aspects of responding to a challenge. And our role is to identify those talents, identify those communities and the people, and then elevate their voices through various products that we develop. And the third thing was create, which is content creation, but also curate the things that other organizations are developing, which are really good. We don't want to like duplicate the work, curate the information, and then provide it to our members. And as you can see, one of the guiding principle is foresight practice, which is thinking about future. And the group has evolved since March, actually. So initially we called ourselves, it was a temporary group to think about like COVID-19 solutions team, we called ourselves. But it was so effective that we have like systemized it now in our organization, and we are calling ourselves solutions team. So we are now thinking about things beyond COVID-19 and identifying pain points. We are in the process of creating sort of a systemized way of getting feedback from members, and then leveraging the talents, and then curating the products or creating the products. So yeah, I just wanted to highlight this new thing that is happening, and I think other organizations can do the same thing. It's really helpful. It has been really good for me especially, and other people working in the group. In terms of the outputs, we do like short-term outputs, let's say, and then long-term outputs. So in terms of rapid response in COVID-19 times, which will take like about a week or 10 days or 2 weeks max to do like blog posts or podcasts or micro contents or resources that are developed by other organizations. These are pretty easy lifts in terms of doing it. And so let's say we hear from a member that, hey, we really need help in terms of doing online public engagement. So it's pretty easy lift to like do a blog post or ask a talent or a champion who is doing sort of virtual public engagement and ask them to have like a podcast with them. So those are pretty easy lifts. And then we are also looking at like in-depth or long-term resources, which is creating educational content around specific topics, doing facilitated panel discussions, and then doing research projects on COVID-19 and related aspects that have been identified by the members. Regarding COVID, of course, there's a web page, a section on planning.org where it takes you to the resources that we have created. Most of them are APA resources, past and present. Like when I say past, I mean the things that we had did pre-COVID and the things that we have done after COVID. And they're divided as per the topics. So topics from like planning methods and tools to land use and transportation and housing, infrastructure, etc. So when person can interested in specific topic and go click and then and see all the resources that we have developed. And this is my last slide. I'll take some time here, just talk about like what have been the focus, just talking about like topics, right? So, and of course there is no, I would like to say there are some academicians in the room, there is no specific methodology for me to say that these are the 6 topics that I think are the top in terms of members' mind right now. This is sort of my biases included, but I think that is what we have been hearing a lot about these 6 topics. Public participation, that was like as soon as COVID happened, we got plethora of emails like in first month talking about like, hey, how do we do public engagement? We are in the process of doing comprehensive planning. We have to do zoning, we have to do public hearings, right? And how do we do public participation? So that was like the initial part. March, April, May was full of like things about like public participation. Initially, it was about doing virtual. Recently, last month and so, we have been hearing about mixed methods, right? So people have started opening their states and communities. It's about how can you do an virtual plus in-person with social distancing participation, public participation. So we have been like right now in the process of developing some content related to that. The second thing we heard was public realm, and public realm was mainly people are talking about how to use parks in the era of COVID-19, because the importance of park was elevated because people cannot go anywhere else. Park is a place where you can do social distancing. So how you can do that? And the second thing that was asked was about public right of way, right? People were closing streets to help small businesses, for people to social distance. So it was about like how is this going to affect the design of public realm? How is it going to change it? We are right now working on a project where we are, this is a long-term deliverable basically, where we are trying to create a guide for the planners to create inclusive and healthy places, and flexibility in public spaces sort of like is an driver that we are looking at to integrate this type of pandemics, like what do you do when there is social distancing in place, etc. The third thing that came was transportation, which is, and this was mainly in context of public transit agencies. And I know you all working in Atlanta, there was a problem. Public transit is struggling, and on many cities throughout the country. So transport, like it was about like, hell, people are not working from home, not taking public transit. So how would it affect public transit? But then it was also about like interaction between transportation and land use. Once people are working from home, I know I work in the DC office of APA, and we have been told that we are not going to office for the next 1.5 year, sort of. So I'm not going to the office, and maybe it will be like, it will come into like permanent work from home situation. We don't know that yet, but how would it affect the land uses? How would it affect the built environment in downtowns where we will have empty real estate, empty parking lots, etc. So how can we use that? So there is this interaction between transportation and land use that has been really elevated by COVID. And these are topic-wise three big topics that I thought I think I thought that like coming to the forefront, and all these topics and beyond this, everything was getting looked at from these three lenses in terms of equity, health. Of course, everything is framed in COVID-19 frame, and then economic impact. People are really worried about the effect of like the work that they do and looking all that work from these three lenses. Equity, I would say that I think we like APA, I would say had not been a champion like in leading when it comes to related to topics of inequities and equity. But since last few months, we have been trying to educate ourselves and have been trying to educate our members about this topic. And APA board and the leadership has identified it to be like one of the topmost topic of importance for APA moving forward. So I'm really excited about that. So for example, equity has impacted, of course, specific group of people. COVID has disproportionately affected a group of people, but then also about digitization of life. So I did a podcast with Pew Charitable Trust in terms of digital divide. How is digital divide impacting the things that has happened, digitization of life that accelerated due to COVID-19? Even though states are working to decrease the digital divide in terms of providing more access to broadband, still the digitization of life is accelerated so much that many people are left behind. So those type of issues. Second thing is health. We've been talking about health a lot. I would like to highlight two specific things. One is the blog post that I wrote like in May after the demise of Chris K, whom many of you know here. Chris K, before his demise, was talking with me like twice a week and had sent me like 70 plus emails in terms of this is what planners should know about COVID-19. And then he created like a six-page document saying that, hey, this is what you need to tell planners. So after he passed away next week, I was like, well, I need to honor him, and we need to tell planners about the public health aspect of COVID-19. So I wrote a blog post as if I'm in conversation with Chris K. So I would say he authored this blog post to let members know that, hey, what is flattening of curve? What is herd immunity? How are the economic impacts of COVID-19? How can planners work on response and recovery, which can be parallel to like what we do in hazards planning, like in climate change, right? So those type of things. So it was very informative, and I know from statistics that the numbers we got that people really liked this blog post. The second thing we did was I did a facilitated discussion with on the topic of how planners can collaborate with public health. And this was a panel of like AICP or certified planners working in public health departments, a panel of them, and they talking about how planners can help respond to the COVID-19, but also help in the recovery processes. Of course, we talked about health equity and how planners can play a role in health equity. And we also talked about the basic differences between the planning, public health and planning, like how they operate, right? And the priorities that are sometimes different in both the departments. So these are the two pieces of resources that I wanted to highlight because it's really helpful to think about health in these terms. And then the final thing is economic impacts. People or members have been worried about the impact of COVID on the communities, of course, but then also on themselves. And we have realized, and I mean, we knew this, that economic impact is sort of like a lagging indicator. So we are not seeing the true effects of recession or whatever that is happening right now, but we may feel, or the communities may feel when it comes to budget, etc., next year, maybe more, and the next 2 years. So we have been really focusing on this and helping planners think about these aspects, like how they can increase the value of planning and thus save their jobs, first of all, but then also thinking about how they can help local businesses through state legislature to federal legislation that are being created, providing help in terms of how they can use these resources, financial resources from states and federal government to help their communities, and how they can apply for different grants, the different opportunities, etc. So thinking a lot about economic impacts as well. So sort of this gives an idea about what we have been focusing. It's not one project, but there's a lot of things that are happening since last few months. I just wanted to highlight a few that we have been doing. So yeah, with that, thank you. And this is my contact information.
Thank you, Sagar. Particularly appreciate the tribute to Chris. All of us who knew him and have worked with him, we're very grateful and appreciative of that.
Yeah.
I knew he would be delighted to see that too.
I'm sure he's watching right now.
So we do have a question in the chat box about if you're aware of any good data or projections about how much of the workforce will be remote after COVID.
No, I don't have a specific answer to that, but I can investigate. We have been through the project that I talked about, the Lincoln project. We have, as I mentioned, we had 96 trends, and now we were able to verify out of this 96 trends, we were able to verify 64 through data. Rest of them were our assumptions or presumptions, seems like. So we removed those, but we do have concrete data on the 64. This is one of the trends. So maybe I don't have on top of my mind, but I can investigate and let you know.
Sure, great. Thank you so much. Bless you. And so we'll move on to Carol now. Carol, I have your slides up, so I will share my screen.
Thank you, Arthine. And I'll just say next slide when it's time for the next one. Sorry, I was having technical difficulties this morning.
No worries.
Okay.
Is everyone able to see my slides? Everyone's able to see the slides?
Okay. I think so, because I see them.
Yeah, unfortunately, I can't. When I'm presenting, I can't watch the chat box. So that's a limitation of BlueJeans, but that's fine. No worries.
Maybe one of our other presenters can help keep an eye on that for us. Mm-hmm. Okay, just to start out, like I said in my introduction, I was given the task to really fulfill our goal with Navicent Health to create healthy communities for everyone. And I want to say I emphasize for everyone because one of our biggest drives is health equity. I was glad to hear Sagar talk about that some, and we did take the pledge in the very beginning to become an equitable organization. And I'm proud to say that in 2018, we won the American Hospital Association Health Equity Award, which is just a great honor. And so what I'm talking about today is a piece of what we did to be able to win that award. There was a lot of other work that went along with it, but this is primarily what we have done around working with our communities. Next slide. So, is it going to the next slide? There you go. So this, when I first took over population health and we were designing to become more healthy communities, that really meant branching out past our original thoughts. Hospitals are now really challenged to enter value-based care, which has forced hospitals to really look at the holistic person, not only when they're in the hospital, but before and after the hospitalization, which for me, as a past social worker and counselor, I came from working in the community. So this was really exciting to me, that I knew that this type of work was going to be really embraced by all hospitals, and ours in particular has done a great job with it. Our hospital generally runs, we have over 500 beds. We are an academic and tertiary hospital, which means we get patients from all over South Georgia, up to about 27 counties, rural, urban. We get everybody. So we started off with care coordination was really already starting to be built, and that was really looking at specifically what do you do with individual patients to help them to become healthier and to manage the diseases that may be there already. What we added was community education, looking more at preventative medicine. And then with the background and with research, we knew that we couldn't do everything from a hospital. It is almost, I would say it would be impossible unless you are financially just really doing well enough to invest millions of dollars into your community. We realized that community partnerships was going to be the primary goal, and to really reach out into areas that were already providing wonderful services and see what we can do to help that to move forward. So this is kind of the overall plethora of different things that were happening. In the blue are the things that we own. In the green is the supporting partners that we have worked with. Next slide. So specifically around care coordination, we looked at much data in our organization to determine where is the biggest need. If you look at in healthcare, generally about 5% of patients that come into a hospital are more advanced, end of life, complex, high dollar spend for those patients. That's about 5%. However, that 5%, if you can make a difference on even a few of working with them, you can really impact the hospital's bottom line and those patients being able to get the care that they need for that complex care. Also, what we did was we took the design of what was coming out through population health, of working with social determinants of health, and then also a counseling perspective that we had used in palliative care, and combined the different ideas of how to manage that advanced illness population to really build a program to where it meets the needs of the patient no matter where they are. There's a lot of behavioral issues with making changes in someone's health, and it is not always easy to make the changes. I mean, heck, many of us cannot lose weight and get out and exercise, and we it's that behavioral, being able to make those changes on our own. So what we did was be able to meet them where they are and help them through the journey, whether they can really get in and make a change toward their outcomes, or help them to make decisions and support them and get their families involved toward end of life. And that made it a program where it was not, there was no failure. It was success no matter which way they went. We did use a lot of screening to be able to determine who was highest risk for coming into the hospital. We have many patients who, because of their social situations, they may not have a primary care physician, and they will come into the hospital ED for any care that they need, which is not necessarily the right place for them to get care. Not only is it high cost for them, it is also taking up beds in a hospital where that really has become an issue nationwide, that we don't have enough beds to be able to take care of all the patients if something happens, such as COVID-19. And I'll talk a little bit about how that's affected us. We also entered into one of the double risk ACO management of patients, which means if we take good care of our patients and are able to keep costs down and meet a large amount of quality measures, then we can actually make an additional amount of money for those patients, which encourages best practices and encourages physicians overall to take good quality care of their patients. However, it also has a side that if you do not meet those standards and you are not being able to provide the quality for those patients, then you will also have the risk of losing money. So it is a great way of encouraging better care. So one thing that has happened with COVID-19, once it hit a community such as it did in Bibb County, it hit mainly around July, shortly after the holiday of July 4th. We saw a record number of patients coming into the hospital. All beds were full, and it wasn't just in Bibb County, it was all of the Georgia hospitals were being affected. So it really made us have to quickly come to planning together and decide, how are we going to manage this overabundance of patients and not enough beds to be able to care for them. So one of the things that I feel fortunate in our community is that we had already worked on this journey toward equity of care. What many people were seeing is patients who were not getting advanced care and getting that preventative type care generally were more at risk for the negative outcomes of COVID-19 and ending up in the hospital with multiple comorbidities and respiratory issues. We already had been working with high-risk patients and had over 500 that we were clearly involved with, and then a couple of thousand more that we had worked with in the past, that we immediately as a team started doing proactive outreach, doing education, making sure that those high-risk patients had the ability to get the care that they needed and understood why it was important for them to be even more vigilant about wearing masks and washing their hands, those types of things, which seemed like a very simple thing, but it really did make a big difference with our high-risk patients. And so going to the next slide. This goes into the community education with COVID-19. Well, before COVID-19, we had really spent a lot of time on access to care. That was a primary goal for us, that we knew that most of our population in the Bibb County area, unfortunately, a high level of poverty. We do have some wonderful services and churches that are willing to provide care. So what we did was a very simple concept of a medical toolkit of all of the main primary diseases that we work with in the hospital and all of the education that we provide. We put together in a box, and we provided to any church that, or even organization that was wanting to be able to do education around these diseases. And it basically left them empowered to either do the education themselves or for us to have someone come do the education. But the toolkit stays with them, and it also connects back to a website that allows them to be able to download and get more of these handouts and ways, a very simple way for people to be able to track their symptoms. Later on, when I started working with Arthi and Georgia Tech, along with Making Bib IT, that led us into some of the research that we've been doing around technology in the neighborhoods. And it kind of brought together the concepts of we're trying to get these ideas and this information out to those that need it in whatever way people feel comfortable, either on paper, whether it's a video, or the other piece that we wanted to do was to have it on websites and technology that would keep these things updated. But through Georgia Tech and the research that the Arthi's team did, we definitely had gaps in there were areas in Macon that did not have access to computers and Wi-Fi or technology. So what we were working on is being able to identify those areas, and then our goal is to put kiosks in those particular neighborhoods that would bring Wi-Fi to them, but also bring the services onto a large kiosk, not only healthcare, but lots of other issues such as where to get their transportation, the public transportation or private transportation. Just anything that they would need would be right there in their neighborhood to be able to access. So access of care has been one of our primary goals. We are a not-for-profit hospital. We do a community health needs assessment that's required by the government every 3 years, and it gives us a real picture of what's going on in our community, not only by disease, but also by social issues. It may be crime, it could be food insecurity. It is done through different focus groups, and then also a lot of phone contact, and gives us the information we need for data to be able to really look at how we can impact the teams and these patients out in the community. Next slide. Oops. Okay. So the next slide is talking about community partnerships. That to me is the real meat of what we do. Because of my background of working in Department of Family and Children's Services, I learned so many community organizations that are really out in all communities doing wonderful services, but they're struggling. They're not for profit, and they really are trying to do good, but may need a little help to be able to get where they need to be. So what we determined was we did not want to come in as a large hospital and tell people how to do things, and that's kind of the way people had seen us in the past. What we did was reach out to these organizations, look at what they were currently doing, and just offer our help. You can see the big pile of apples and oranges that are in this picture. During COVID-19, food insecurity was an extreme issue in our area and pretty much all over. We have done a massive amount of food distribution through churches in our community, and then Navicent Health has done 2 really large food distributions in areas that we knew did not have access to food. We also have included our legal. We have a partnership with our Georgia legal services here to be able to provide free legal services to those that normally would not have access to that, which going back to the first presentation of talking about mold and things that may be in a building, that is something that we would deal with our MedLaw program to be able to help patients in their housing and be able to get the care that they need to be able to get mold out of their home, which could be causing asthma or COPD exacerbations, other things such as that. Next slide. There's so much to talk about that I'm sorry, there may be things that you may see on the slide that I don't talk about, but I just wanted to hit main things that we've been doing. One of the things that, as a matter of fact, we're getting ready to be presenting this at the IISE organization for engineering for a CAP award. We were nominated for the top 10 for what we did in this area. We actually knew that it was just daunting how much we would have to do to be able to impact our community, and we needed to know what was the focus areas. And so what we did was we used geospatial mapping to really look at where patients live, and then by diseases, what areas, what neighborhoods were impacted the most by people coming to our hospital, and then also connecting it to what their income per house was, which really gave us down to specific neighborhoods of areas that we needed to focus in for health equity. And then the little pieces that are on this map really show the different programs that we did. That was some of those community programs that I talked about, the churches, the screenings, and all of the other items that we did throughout this area. Next slide. So on the next slide, it just talks about what we knew. We had to be able to prove these services that we're providing are free. It is not something we bill for. It is my job to constantly be able to show the worth of why we're doing this. So what we're always looking at is decreasing unnecessary ER visits, preventable hospital readmissions and admissions, and then decreasing any barriers to care for our patients so that they can live healthier. And then we want to increase self-support by providing the services such as that kiosk or other programs. We want to have things that people now know about through some technologies we have that connect people, to give them the ability to get the care they need and remove those barriers, and then once again live healthier. So the next slide just shows a little quick data of why this is so helpful for hospitals. We did one program, which was the advanced illness program I talked about in the beginning. We took a sample of the patients that we worked with and determined what their cost had been, and what by decrease in hospitalizations, we were able to actually have a $2 million savings to the bottom line for the hospital. And this also opened up 323 new beds for patients to be able to come in, which really made a difference through COVID-19 and in our ability to take care of a large mass number of patients at one time. We also did a program that was called Transitional Care, where we identified patients who did not have a primary care physician. And while they were in the hospital, we worked with our federally qualified health center to allow them to come and be able to offer their services, to be able to see them within 7 to 10 days. And by doing that, you can see on the next slide the outcomes And I'm trying to go through these a little quickly. So you can go to the next slide. I'm sorry, I'm going through without telling you. So go to the next slide. So this is the data that actually showed that the patients that we enrolled into the federally qualified health center and were able to get there within 7 to 10 days, that they decreased their readmissions back to the hospital by 68.8%, which was really phenomenal with this the patients that needed it the most. These are generally the patients that we are seeing coming back and forth to the hospital because they were not being able to follow up with a physician afterwards. Next slide. So the next slide, actually, this is one thing that we ended up having to quickly put together. Saga talked about how COVID-19 really pushed those of us that like to plan and look at data and really make good decisions. We had to just really drop and go straight into putting together a program in order to get these patients. We were running, as I said earlier, we were running 450 or so patients on a regular census in the hospital. During COVID-19, it got up to about 550, and we ran out of nurses before we ran out of anything else. And that was very apparent across the nation. I believe that we realized that we've always heard that we had a shortage of physicians and nurses, but COVID-19 brought that to the forefront. So we quickly, through our corporate office, through Atrium Health in Charlotte, we came up with the idea of doing virtual visits, and we were able to take people out of the hospital or out of the emergency department, take them home, and be able to virtually take care of them in their home in their bed while they had COVID-19. And this really decompressed the hospital very quickly. We saw within the 2 months that we had to put this together, we saw over 100 patients that we managed at home. So COVID-19 has really made us all have to think in different directions and be quick on our feet. And to me, in healthcare, that's where we all have to be, is building the infrastructure, planning, and designing for things that we don't even know are coming. And that makes it very interesting in our world now. And I'll take any questions or anything that I can discuss. I'll be glad. I didn't put my contact information on there, so you can call Arthi.
I think, Carol, there was one question from Whitney to ask you, are these access locations that you showed are available publicly?
Are they what? What was that? I'm sorry.
Are they available publicly?
Yes. Actually, I think we've even published some of this data. We did it individually per patient. We cannot publicize that because of HIPAA violations. However, we do have it to where we did in areas where it just summarizes for each area. So I'll be glad to share that with you.
Thank you.
Okay.
And yeah, I misunderstood the question, Arthi, that you asked before. I thought how many people will be, I thought you were asking about unemployment. I don't know, didn't think about like remote working, but I'm reading Catherine's question now in terms of how much of the workforce will be remote after COVID-19. Have a couple of data points regarding that. There was this survey done in April. So of course things have changed, but in April there was done by Gartner. They interviewed about, I forgot the sample size, CEOs or CFOs, and 74% of them thought that they are thinking about allowing people to either work permanently or sometime remotely. So that was a staggering number, 74% of CEOs saying that. And then Brookings did a survey of 8,000 employed adults in, I would say before 2 months or so. No, I would say about 3 months or so ago. And they found that about 50% of them were either working part-time, or part-time. They were either working some hours or all hours from home. of course, that was because of COVID-19. And then there was this third survey that came from not so reputed research organizations. I'm not sure whether it's true, but they did interview CEOs and CFOs again. This was before 2 or 3 months. Again, they they found that about 20% of CEOs and CFOs are thinking that are thinking of either allowing people to work completely remotely or allowing them to work remotely some days of week.
Great, thank you.
I'd like to add into that. During COVID-19, because of being in the hospital, they did allow many of our groups to go remote. And we are now doing studies across Atrium Health and looking at the cost savings, because some of these were in buildings that we were paying for. And they've already realized, first of all, the productivity was greater for those that worked at home. And it will be millions of dollars in savings for those buildings that we will no longer have to rent or pay for. So I do see that has made us quickly moved into the future of remote work. Even my group of care coordinators, I would have never thought that I would trust people to work at home, but they are twice as productive at home as they are in the office.
Actually, all of these trends.
I will just add a quick comment there. For anyone that works on pre and post occupancy evaluations, I think this is a very important time. We're tracking businesses that are looking at people's satisfaction from working from home and the sort of resiliency factors of whether or not you feel connected, whether you feel isolated.
Yeah.
And anyway, so we're going to be actually sharing that. I think December 10th, we'll be looking at some research specifically on data from work from home from organizations that had pre-data before the pandemic. So I just want to put it out there that I think that's, from a data collection perspective, very interesting as we're moving into home environments. And I will just ping that mental health in particular is something we're closely tracking when people may be in isolation and we're not able to see them in the workspace the same way.
That would be amazing. And I would just continue the thought and saying that we did a session in April where we talked about mental health in COVID-19 era. So we had a social worker in the panel, but then also had Kathy Wolf from Washington, who is a leader in terms of nature and health. So the importance of parks and the green spaces, etc., would amplify so much. People are working from home. They need to walk. They need to go somewhere else other than not meeting the employees. So they need they need to self-care, and one of those things that they can do is basically going to parks, going to green spaces, etc. So the importance of that has increased a lot.
I think on the planning and design side, I'm hoping that some people will really research too of it's a whole new world. I mean, we're hiring 3 new care coordinators and trying to figure out how are we going to train people when there's nobody here to train them. So there's just a lot to think about, and it's a very interesting time for us. The virtual care of patients in the home has also been a really learning experience. I think that COVID-19 moved that forward just exponentially, and seeing how people react to having their doctor on a screen rather than going to them is going to be very interesting.
Well, we are 1 minute away from 9, so I think we have time for maybe one more question from the audience.
Can I ask a question to Whitney? I may have missed this, but are you also thinking about WELL for neighborhoods?
Oh, that's the question.
Yeah.
So we have the WELL community standard.
Okay.
So I encourage you to check that out. There are conversations underway on the WELL city level. And Sagar, I was actually just about to send you an email because we're doing some really exciting work with Cincinnati. And they're coming forward with their vision plan, and they're referencing WELL. And that's really powerful for us to actually be a reference document as these, neighborhoods cities, communities, regions are building. I think one thing that we are learning, I'll just kind of open this up, is who is our point of contact in pursuing well community? Is it the developer? Who's the team? I think we're really trying to partner with like the eco districts and groups that are out there that are pulling multiple tools together. Dr. Dannenberg, I see you on the line. It's wonderful to see you in the virtual space. I think a big challenge as we move into communities is that we'll be bringing our experts on to advise us, and we're trying not to recreate any tools that are already out there. So, the goal is, what have we learned? How do we move this forward? But also, how do we create a program that's accessible and not so cumbersome the market is still able to take that on? So we are open, we are supportive to learning, and I mean, partnership is very key. We're a relatively small group, and so as we learn, that's going to be, really, really critical. And Carol, we're moving into healthcare too, so we are standing up that advisory. And I would love to talk to you about community health needs assessments, this other powerful tool that I think could be part of a well community standard or well healthcare standard. So great discussion, early morning discussion with everyone. Maybe just my overtime comment is we need your help. And, thank you for all the experts and for signing on. It's great to see some people's faces here and hope to be able to work with you moving forward.
Well, in the interest of time and just to be respectful of everybody's schedules for the day, I just wanted to profusely thank the panelists, particularly for this very interdisciplinary kind of discussion. This is exactly what we hoped for, and we see the connections emerging, and so nothing more exciting than that. I think the students will be very eager to see this as well. So I really, really, really appreciate all of your insights, for taking the time to join us this early in the morning. And thank you all, and have a wonderful rest of the day. Of course, if I have any questions, come in at a later time. It looks like folks really want to keep talking about this. I think the guests were very excited about this. So for sure, I will reach out to you. And I'm going to stay in touch with all of you. So I look forward to continuing this discussion. Thank you so much. Appreciate everyone joining us today. Thank you.
Thanks everyone. Be well. Take care.
Bye.